Good afternoon, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family physician here in Vincennes, Indiana, Chief Medical Officer of our physician group. I'm joined, as always, by Adam Thacker, who's our Chief Operating Officer and also a pharmacist. We'll be giving you an update this week on where the status of COVID is in our area, a little bit of statistics, and then following that up with kind of where we see things going over the course of the next few months. A lot has changed since we've done our update over the last few weeks or so. So we'll be talking a bit to the new variants, what we're seeing out of those in terms of infectivity, and then also virulence of that as well. So if we start off with the numbers, about 4,000 total positives that we've had, but that doesn't really matter as much as that positivity rate. The all positivity rate that we've been seeing escalate over the course of the past week or so is around 13 to 14%. That has doubled in the course of the past week or so. The other more important number is really that unique individual number, right, which is around 29%. And then I think you can speak to what we've just seen in our ambulatory clinics as a positivity rate of all tests done that's anywhere from 30% plus.
Right, and consistently, not just a day here or there, but for the last 2 weeks, we have seen pretty consistent, when we're running tests in our ambulatory offices, primary care offices, convenient care, that about 30 to 33, 34% of the tests we run are testing positive for COVID. And when I looked back at some of the numbers, in the last 30 days, we've seen 324 positive cases. The previous 60 days, those 30 days plus 30 more, an additional 22 cases. It's over 1,000% increase in just the last 30 days. So when we talk about the Delta variant, the transmissibility of the Delta variant, how much more transmissible it is, it certainly is proving to be true that outdoor, while we know is a lower risk, there still is a risk. There's some incidences nationally of outdoor events that have had, those spreader type of events, and indoor increases that risk. But we're certainly seeing that transmission, and here at Good Samaritan with our testing, we're seeing it, that 400% increase in the number of tests we're running in the ambulatory space. And unfortunately, as we talked before, when we were still seeing a few positive cases, it was staying predominantly outpatient. Felt like it wasn't really hitting needing hospitalization, putting pressure on healthcare. But unfortunately, that's shifted this week pretty dramatically. That our inpatient census, while it had been climbing, has now we're in the teens of patients. Half of our inpatients are requiring ICU level care, and that's a scary situation because you start to recall back to last fall, and we were in a situation where that continued to climb, and saw a lot of ICU patients, a lot of ventilator needs, and that acuity of illness is high, and that's unfortunately where we start to run into patients can't recover and we have deaths.
Right. And as Adam is speaking to, one of the things that's important to consider is that population that we're seeing admitted frequently is unvaccinated and has other comorbidities, so other illnesses. And this goes right back to kind of where we were before. There's a lot of talk at this point in time as to why do we still suggest getting vaccinated? Why is there still a push for vaccination? And when we look at hospital systems like the Cleveland Clinic study, where they looked at all the people that were admitted to the hospital for inpatient stays, 99% plus of those were unvaccinated. And I can certainly speak to what I have seen in my clinic population, which is there are some people who are coming in that have been vaccinated that are coming down with symptoms and are positive, but none of those patients are requiring hospitalization, and they're not getting the more significant illness from it. But the patients that I have seen that end up getting admitted to the hospital and requiring additional treatment have been unvaccinated, and typically ones that have risk factors. So while we did an incredible job, and our population in this area did wonderfully in January, February, and March, getting out and getting vaccinated as we marched from 80 plus, 70 plus, 60 plus, so forth, and went down through our older population and more sick population, that population has had months to get updated on their vaccines, and we're really looking and hoping that we see a continuation of that on people who are now rethinking it and going, well, maybe I should have gone out and gotten my vaccine.
Right. Since December 17th, when we started administering the Pfizer vaccine here, the message hasn't changed from that standpoint, in that the safest path forward and the safest direction is to get vaccinated. And that's been an extremely debated topic and very polarizing and picking of sides, which many things COVID have. But we look at the data, and we trust modern medicine, and vaccines have proven to do exactly what they're supposed to do, which is to preserve life. So we don't have patients that are vaccinated ending up in the hospital and dying. The vast majority, like you said, 99% are unvaccinated, and that holds true for Good Samaritan. That's what our State Department of Health is reporting. That's what the national numbers are reporting. So we're not seeing anything unique. But the unfortunate other side of that is 43% of our population are vaccinated. And you look at ages 12 and older that are eligible to be vaccinated. If you break it down into a simple risk benefit, risk reward, the risk of, and I saw this stat from the State Department of Health the other day, the risk of getting COVID and ending up in the hospital is 1 in 237 if you're positive with COVID. If you are vaccinated and get COVID, the risk of ending up in the hospital is 1 in over 20,000. So whether you gamble and play the odds, whether you're just a numbers person, they all point in the same direction, that is our safest path forward. And there seems to be a misnomer of there's breakthrough infections, so the vaccine doesn't work. Well, we know that's the exact same as with flu and other viral vaccines. It does not keep you from becoming infected and testing positive. So if you're a vaccinated individual, come in contact with COVID, come to our clinic and get tested 3 to 5 days later, there's a high likelihood you're going to test positive. But your symptoms are going to be milder. You're going to be able to recover at home, a shorter duration of illness if you do have any symptoms at all, rather than being hospitalized. And there are a few. And just in full transparency, while the vast majority of our patients at Good Samaritan have been unvaccinated, there have been a few admissions that have been vaccinated. But you start to look at comorbidities and heart failures and diabetics, immunosuppressive agents. We talk about cancer patients a lot, where the vaccine didn't create enough of a antibody response or immune system response to protect them fully. But you've got to imagine on the flip side of that, what if there wasn't any protection at all? Would they have even made it to the hospital and have a fighting chance? I mean, I continue to believe that is absolutely the best path forward. And again, being a data person, it's just it's undeniable to look at the data and say this works. And kind of the last soapbox piece of that I'll mention with the vaccine is I saw this, I'll call it a disturbing data set from a survey that 53% of Kaiser Permanente survey said that they were more scared of the risk of the vaccine than of COVID. Well, the risk of the vaccine, we gave over 24,000 doses here at Good Samaritan, and we had 0 patients that went to the ER, that ended up in the hospital, that needed an EpiPen or had an anaphylactic reaction. Most people hung out for 15 minutes observation, visited, drank water, and watched the slideshow on what the vaccines, how they worked and that type of thing. We just didn't see that. And the 380 million doses that have been given, the rate of severe reaction is exceptionally low. It's actually a pharmacist colleague of mine out in the St. Louis area posted something. This vaccine, there's less hospitalizations, and statistically it's safer than ibuprofen. And we all take ibuprofen when we have joints hurt, headache, whatever the case may be, but we don't look at it that way because it was new and it was rushed when it really wasn't.
And it's, Adam and I are literally bombarded with dozens and dozens of forwarded videos from the internet and some of the experts on Facebook. Thank you all for that. But the important thing to keep in mind is a lot of the controversies and discussions and these really hot topics fail to address what we're talking about here, which is the at-risk population. We can argue back and forth as to whether or not a healthy 30-year-old or a healthy 15-year-old or a healthy 50-year-old is going to benefit as much from the vaccine as a person who's 65, 75, 85. But that's only a little piece of the puzzle that we're talking about here, which is trying to prevent the perpetuation of that virus and the growth and mutation of that virus and the spread to that population that is at risk. And that's really what we're talking about. And so many hot button topics as far as vaccines required at workplaces and vaccines required at schools and all those types of things. there are certain things that we all sacrifice based on our professions. If you're a firefighter, you don't get to have a beard. If you work in food services, you need to wear gloves. You have to wear a hairnet. All of these things are sacrifices that are made based upon the choices of your profession. And as we look forward to this, it's important to realize that that carries across all of medicine and all of healthcare and all types of industries. So what we are talking about is not just whether this individual or that individual needs a vaccine, should wear a mask, so forth, but the global good here and our local population and our hospital staff and all of us are keeping that in consideration. So when you get the crazy viral video that gets forwarded to you, make sure you listen to it carefully. One of the favorite ones that I received recently was a person extolling their expert treatment of COVID, and they had treated 15 patients. I'm like, fantastic, that's spectacular. We have treated hundreds and hundreds of patients with this and vaccinated thousands and thousands of people. And so, as Adam said, we try to stick with the science, the data, the stuff that is blinded and controlled, so we know that we can believe that information. And as scientists, that's really what our goal is. One of the things that we also anticipate that's going to be coming up immediately is what normally happens when school opens, which is a rise in normal viral illnesses. Those are typically respiratory illnesses, those are typically GI illnesses. So there's going to be a tremendous amount of overlap with that happening with the spike that we're experiencing right now. Now, the good news, we hope, is when we look at other areas where they have seen this similar spike, is it has been rapid up and rapid down, and that's certainly what we're hoping for as well. And that also mirrors what typically happens at this time of year, usually about 2 weeks after the schools open. Everybody rushes back inside, everybody comes home with snotty noses and diarrhea and so forth. The problem is that's going to be confusing as it compares to what's going on with COVID. So we want people to be attentive to those symptoms, to their children's symptoms. We want them to pull their children and school-age children out and make sure that they are fully recovered before they go back to school. And then as far as testing is concerned, obviously, as Adam has noted, there's been a tremendous rise in the amount of tests that we have been responsible for taking care of recently. And we want individuals who are symptomatic to get out and get tested because we want to identify those people. Furthermore, we want to identify those people that need treatment, monoclonal antibody therapy, which we'll talk about in a bit. But also, there are people who are coming in to get tested that are asymptomatic. And while we can do that, there's not tremendous clinical value in that.
Right. And that's the key word, the clinical value. So as medical providers and Good Samaritan, from a healthcare standpoint, we're looking to identify patients that are sick, that need medical treatment, whether it's monoclonal antibody therapy, whether it is another form of treatment. So asymptomatic exposures, and the CDC has recommended this. Let's just, kind of call that what it is. The CDC has recommended if you are a known exposure to COVID positive, that 3 to 5 days post that exposure, you should get tested. That is for surveillance of data and epidemiological uses, which is where they look at, how many vaccinated are testing positive, how many unvaccinated are testing positive, and then what's the outcome of that. Vaccinated, unvaccinated, if you have symptoms, we'll take care of you. We'll treat your symptoms. That's what you do with viruses, is you manage the patient in front of you and the symptoms, and then you treat them effectively in that mechanism. So yes, you can get tested, but we're not, from a clinical care standpoint, we're not promoting that everybody should go and get tested. Now, if you start to develop any symptoms or are high risk, absolutely, you should get tested. And a lot of that ties into what we know from our best path right now, other than hospitalization, is that upon a confirmation of COVID positive, if you are high risk, having symptoms that may be trending towards potentially needing hospital level of care, can receive monoclonal antibody therapy, which is approved under the FDA emergency use authorization therapy. It's an infusion that is given outpatient, and it binds to the COVID protein and helps to neutralize COVID in the body while allowing your immune system to get a boost and respond. And similar to other increases, you've seen go from we were giving 0 to we're giving in the teens every day. And thankfully, many of those patients, not 100%, but it's kind of back to that 95 plus, are staying out of the hospital.
Yeah, and we see a quicker turnaround of that illness the sooner in the illness that you're diagnosed and treated with monoclonal antibody. The challenge that we have seen just in the course of the past few weeks is Symptoms are milder with this variant, so people don't have fevers, chills, they don't get hit quite as hard and quite as fast. They have mostly mild upper respiratory symptoms. I've had a number of patients come in complaining of this as their typical allergy symptom that they have, typical sinus symptoms that they have, diarrhea, cramps, stomach flu type symptoms. So sometimes it goes a little bit underdiagnosed early on or underrecognized by the patient because the symptoms are milder. So we ask everybody to pay attention to those symptoms, and if you think you are becoming symptomatic, please come in and get tested. If you are not symptomatic, we want you to hold off, communicate with your providers, let us know if something's happening, and then that allows us to make sure that we're getting those patients that are most acutely ill as quickly taken care of. And then, as Adam said, really uniquely, our system here at Good Samaritan and only a couple of other systems regionally in Indiana are using the monoclonal antibody as we are. It's been quite spectacular that we have had allocations early on and been able to utilize this because we've seen a very rapid turnaround in illness in a number of patients who would have otherwise been very high risk, who are diagnosed on day 2, 3, or 4, receive the monoclonal antibody. We call in to check with them a day or two later, and they feel incredibly better. So we still want to carry that through, but we also want to make sure that we keep the capacity for those patients that are most ill. Because right now, as Adam said, we went from giving 0 of this 3 or 4 weeks ago to over the course of the past week or two, ramping up to 15, 16, 20 of these a day. So as school starts back up, as kids are starting to get back into the systems of education, just be cognizant of that and also of your own symptoms to make sure that if that's happening, we get those people isolated, we get them quarantined if necessary, and then we make sure that they get diagnosed early on if we need to do some treatment with them.
Right. That's an excellent point. And the monoclonal antibody therapy has been a tremendous tool in being able to treat patients. But I would add it's important to put in the plug because I see some of the MAB therapy articles talk about passive vaccination. It is not a replacement for getting vaccinated. We're still pushing that. Even if you have had COVID, once fully recovered, should still get vaccinated. Another question that we get is vaccinated versus unvaccinated. What's that mean for quarantine? How's that work? So we pretty strictly follow our CDC guidelines, our Indiana State Department of Health guidelines, public health measures. And if you are vaccinated and are an exposure, asymptomatic, do not have to quarantine. Recommendation is to wear a mask, especially for the first few days, because we know symptoms typically develop 3 to 5 days after that exposure. And also this on the masking piece, we are in now that high area of transmission. So CDC has recommended basically all 92 counties in Indiana are recommended that masking indoors should be done. It's not an executive order yet. I think that we're on our way there if we don't kind of step up and start doing what is right to prevent transmission, but we're not there today. And then from an unvaccinated standpoint, if you're unvaccinated and a known exposure, then you should quarantine. Quarantine is 14 days, or there are alternative based off of a negative test or no symptoms developing and needing to return to work. But the gold standard is still that 14 days.
Yep. And there are a lot of things that have been happening over the course of the past week or so as far as school policies are concerned. When we get another couple weeks along and do another update, we'll have more information with regards to that. But as of this moment, schools are not requiring masking.
Correct.
Certainly, as far as identifying those students that develop symptoms, pulling them out, getting them isolated, quarantined is very important. But we'll obviously have more information data as to how this has played out. It's easy to play Monday morning quarterback. I get that with patients and people who are anti-vaxxers and anti-COVID precautions and so forth. But what we have to keep in mind is this is a very fluid process. And every day we are having meetings and looking at data and deciding as to what's best for our population. The schools are doing the same thing. We want our kids to be in school. We want our kids to be in sports. So ideally, that is the goal that we are heading towards. However, ultimately, as this progresses and as week by week goes by and we look at numbers, Dr. Stewart looks at numbers, there will be changes that go along with that. So don't everybody get married to exactly where we are at this point in time, because this is something that is a very fluid process. As far as testing, would you talk a little bit about what all has happened in the last few days or so, because the availability of testing and how we're sorting that out here in town has changed?
Sure. As we've seen an increased demand, our convenient care test sites, convenient care on Willow and the Willow Plaza, convenient care at Williams Brothers off Washington, as well as effective today have stood up our MCV, Medical Center of Vincennes testing site, to add a third site based off of the increasing demand that we have been seeing, and not wanting to bring multiple patients throughout the medical center, and concerns of exposures in those common areas of hallways, waiting rooms, etc. While we take every precaution possible, and masks are mandatory throughout all healthcare, all Good Samaritan healthcare facilities, there's still always that risk that that we do pull the mask down, or that there's transmission. So test sites are those 3 test sites. And the convenient care sites, there's a park and call. You can come out there and be seen without an appointment through a medical center with your provider. They can see you virtually, or may talk to you over the phone, and will send you to the test site to be tested. And that may be for COVID, that may be for flu, anything that's aerosolizing where there would be a risk of exposure would be tested there, and then your provider will follow up with you based off of the results of that test.
Yeah. And I think it's important to kind of line out who is an ideal park and call patient, because I think there's a lot of question and concern about that. If you have risk factors, if you are older, if there's a chance that your illness is progressing, you're getting more ill, you are not a really great park and call candidate. You should be a be seen person, because ideally what we have to do is make decisions with regards to whether you need to be admitted to the hospital, how sick you are, what your oxygen level is, and if you're a candidate for monoclonal antibody therapy. So we've had a tremendous influx of people who have been park and call type patients coming in to get the test done, and then they want to know, well, what do I do now? So unfortunately, as it stands, park and call means you park, you call, you get tested, you get your results, and then you're on your way. And the unfortunate thing is then that leaves a lot of unanswered questions as to what we do next. Everybody gets a handout in terms of if their test is positive, what their quarantine, isolation, contacts, and so forth should be. But we need to, again, think clinically in terms of what might that next step be. So if you choose to go and have the park and call option, it's important that you kind of think about those things ahead of time, because it's entirely possible that you need to be seen. We've ramped up the availability of providers in those locations. We're shifting things around with our primary care offices so we can increase that volume at each of those locations as well. So we apologize for any wait that people have, but we want to get as many people in and seen that need to be seen in those clinical settings. Yeah. So one thing that people kind of are curious about is, again, stepping back to which vaccine should I get? I get this asked quite frequently. Should I get the mRNA technology vaccines? Should I get a traditional vaccine? And really, you should get a vaccine, is what it boils down to. The safety is unquestionable. As Adam has said, people keep sending me emails, thank you very much, about the statistics and how possibly this could have all been approved in such a short period of time. But what we see is there has never been a vaccine that has more clinical data on it in such a short period of time as what these vaccines have. I'm not normally a promoter of any specific name brand anything, but Netflix has an incredible program that describes exactly what the technology is behind mRNA vaccines. And what we believe is that many more vaccines in the future are going to be utilizing the same technology. And one of the benefits of that is the allergy-related issue.
Yeah, and so when we look at the vaccines, again, all 3 have really shown tremendous safety and efficacy profiles. The Pfizer and Moderna are the 2 that are made with the newer mRNA technology that we tag as newer, but the technology of using mRNA to deliver messages to our body to create an immune response and have a targeted cell response has been used in the oncology field for decade plus using this same technology. It just had not proved to be a vaccine approach. Pfizer head development is very well documented as saying the reason they went that direction was at the speed that they felt like they could move with that. You also have to step all the way back to the beginning and realize that vaccines in the past were not a race to get this done. And so the collecting the virus and knowing what would work against that virus, very early on, the virus was identified and that genetic code of the virus was sent out to say, let's get a vaccine created. So the world really worked together rather than it being somewhat of a business proposition, for lack of better words. Those are the two mRNA vaccines, and then you have the Johnson & Johnson, which is the single-shot vector vaccine. So the mRNA vaccines are 2 shots, a very low side effect profile, and all 3 of them, the side effect profile is similar in that mild fever, chills, tiredness, just general weakness, the exact same side effect profile as the influenza vaccine. And one thing that I know you tell your patients, I talk as a pharmacist to many individuals and patients, is that a response from your body of mild fever, chills, tiredness is not only somewhat expected, it's a good thing. Yep. Because your body is responding. Your body's immune system is saying, I got the code, I need to create antibodies to fight off this intruder in the SARS-CoV-2 virus, and I'm doing that. So your body creates a response, no different than it does in any other foreign pathogen that it sees. The vector vaccine, the Johnson & Johnson, delivers a similar message telling your body to create the antibodies to fight this off and then remember it for next time, but it's just delivered in the more traditional vaccine mechanism, which is to take a similar virus but a different virus. So in this case, it was the adenovirus that it delivered a small code to say, create antibodies to attack the spike protein of SARS-CoV-2 and remember it. So next time it enters your body, before it has those 2-3 days to build up a high viral load, your body goes into effect and starts fighting it. That is why you can test positive, have mild symptoms, versus unvaccinated. You're going to have severe symptoms because the viral load builds before our body can respond against it. But the side effect profile is unquestionably, from a data standpoint, been reported as extremely low as compared to other vaccines. And from a safety standpoint, we continue to just see hundreds of thousands of doses given across the board, and now we're in the hundreds of millions total, and have seen very, very few severe reactions. And we look at those severe reactions as requiring intervention. So you had to give an EpiPen because somebody's throat was swelling shut. That's severe. You had to go to the ER. You had to be hospitalized. It's not to say that wouldn't ever happen, but when we're starting to talk about hundreds of millions of doses given, we can probably draw inferences to somebody who got the vaccine and had a cup of coffee and ended up in the hospital, so maybe it was the cup of coffee. I mean, it's just but instead we're looking at it with such a microscope to say, well, it had to be the vaccine, and we cast this wide net of anything happening that now is the vaccine, when truth be told, there's no live virus in it. You can't get COVID from the vaccine. The ingredients in it are simply that message being delivered, and then a solvent to be able to liquefy, to send it into your body, that is used in all kinds of medications and drinks that you drink and those types of things. There's probably things in soda that you have more documented risk than you do against this with what's in the vaccine.
That's a totally separate program.
Yeah. So that's the side effect profile, and the safety efficacy have really been unparalleled.
There are very few things, and when people ask me, is it safe for me to get the vaccine, would I say, no, you probably shouldn't get it. And really that has just been severe allergic reactions in the past to vaccines, Guillain-Barré, which is a progressive neurological illness where you demyelinate your cells and you lose strength in your extremities. There are very few things that would fit into those categories. So in general, any of the vaccines are safe. We would promote them. We had the Pfizer vaccine. My family has had the Pfizer vaccine. So from that standpoint, that has been the one that we've had. But I think all of them, efficacy-wise, are looking good. The 2 mRNA vaccines, Pfizer and Moderna, have better numbers right now. But for people who are uncomfortable with that and would prefer a traditional vaccine, the J&J vaccine is prepared in just that manner.
And I think the next question coming from a vaccine development standpoint, next 2 questions, is it's under emergency use. So when will full FDA approval be granted? It's expected by the end of this month, early September, that will be granted full approval. And what that means is that they're analyzing all of the data, and it will be fully approved like any other drug or vaccine that the FDA reviews and puts on the market. And then the next question after that we get a lot is, what about a booster? And right now, we know that FDA, CDC are not recommending boosters just be rolled out. But other countries have seen some success with that immunocompromised at-risk group that we've talked about that may not mount the full antibody response, immune response from the 2-shot or 1-shot, that another shot has provided protection. Israel is a country that has been well documented. They rolled that out and have had some success. So I know some of the leaders in our country from an infectious disease standpoint and CDC have commented that I think that's likely that is coming, but it's not everybody go get your 3rd shot or your 2nd shot. It's likely a small subset of groups that are the higher risk.
Any other major topics before we get some questions?
Only other thing I would mention that we didn't get to is effective Monday, we will be rolling out or implementing new visitor restrictions. So across all of our outpatient areas, ambulatory offices, outpatient testing, patient and visitor screening will be going back into place, and visitors in those areas will only be allowed if involved in medical decision making or for mobility of patients to get to and from one location. At this time, our inpatient visitation has not changed. We're continuing to watch that. Our visitation restrictions flow with our color coding county map, and as we move into red, we need to take every safety precaution for patients coming in here to seek care that we can, and that includes limiting traffic.
Yep, certainly. Kristen, you have some questions for us from our online folks.
Yes. The first one, how will this new strain affect an unvaccinated child?
So how will the new strain affect an unvaccinated child? So the good news is that in the majority of the pediatric population, the adolescent population as well, we don't see tremendously severe illness with this. There was some concern with the original variant with some cardiovascular issues in the adolescent population. Certainly we don't have enough time to see what's happened with regards to Delta, but the majority of the younger population, we are seeing more COVID positive children now with this wave than we saw with the first wave, probably because of the infectivity and probably because we've gotten kind of loosey-goosey with everything in society. But I have not seen any children that have gotten significantly ill. Certainly we've had none that have been admitted here, none within our practice that have required any other intervention other than supportive care. So that population we are not nearly as worried about, but that population is also going to be the population that we worry about carrying this virus on to other individuals. So as we were talking earlier about that normal 2-week after school starts that everybody's got snotty noses and diarrhea, that population, that vector, that group of individuals is going to be the population that sustains this virus longer.
And no different than in an older adult population, it goes back to the strength of our immune system. And so if you have a child that their immune system is weak or weaker due to they have a known illness, those types of things, then we still know that masks work. They help prevent spread. They provide some protection to you, but also to others. So would certainly encourage, if you do have a child that's at higher risk for an infection, that wear a mask.
Yes.
Okay, the next one, any idea yet how long the vaccine will maintain adequate antibody levels post-vaccination?
There's not sufficient data to say for sure this is the date. What ties back to the recommendation for the at-risk, weakened immune system population to potentially get a booster is that there are reports from Pfizer studies as well as Moderna that at about that 6 to 8 month mark, they did notice some decreasing antibody levels. But again, that doesn't exactly amount to the immune response will or won't be sufficient. There's so many factors that play into that. What we do know is that we're looking 6 to 8 months out and we still have antibodies and we still have that protection in our system. So that's good news. But there has been some decreasing levels at that point.
One of the interesting things that I think we were all kind of waiting to see was, does natural immunity versus active immunity from a vaccine, which one wins out? And I think we would all like to think that our natural immunity is going to be the spectacular better answer, but interestingly the studies have not necessarily shown that to be the case. And we have seen here locally in our patient population people that had it last March that then got it in October, people who had it last summer that then got it in December, people who had it in January have it again now. So the I'm going to sit and wait and maybe I get it and then I have better immunity is not playing out like we thought it was going to.
Right.
That's a neat thought, and we would all like to think that that's going to be the case. But unfortunately, again, the statistics have not necessarily played out that that's going to be the case.
Well, and we have to go back to science. And so when you go back to science, and one of the things that you learn in evaluating research and studies and looking at literature is what are the controlled variables, what are the uncontrolled variables. So when you're looking at immunity, active immunity, vaccine-mediated immunity, or natural immunity, the natural immunity, the immediate question that comes up is, how sick were you? So did your body have to mount a full response and then you recovered? Or did you have very mild illness and your body may not have mounted that full response, so now you're more susceptible to a reinfection? With vaccine, controlled studies tell us we gave this amount and said to create this response, and this is the response that you're going to get. So there's less uncontrolled variables. You have more controlled elements versus the other. It's hard to know. Somebody that truly had an illness and mounted that response may have adequate response, but then the other factor that really just points us to step up and get vaccinated is that as newer strains have emerged, the natural immunity response is at a different place in the binding proteins of COVID than the vaccine, and the vaccine has been less impacted in efficacy by those mutations and variants from alpha, beta, delta than what natural has. And unfortunately, as we likely see other variants, natural immunity will prove to be less and less effective.
Yeah, and again, boosters are nothing new.
Right.
You and I have lived through, what is the tetanus, diphtheria, and pertussis interval? Well, maybe it's 6 years, maybe it's 10 years. What's the pneumonia vaccine booster interval? Well, it used to be every 6 years from age 50. Then it was once at 65, once after 65. What is the booster status for shingles vaccine? Well, you get one, and then you get a booster 3 months later. So this is not something unique with COVID vaccine to need a booster. And the thing about it is, as these studies continue to be conducted, we have more of those antibody levels, and we can statistically see what the numbers are in terms of likely to get it after you've been vaccinated. That's where the answers are coming along. And this has played out. I've been a doctor for 23 years, and we've continued to see that evolution of tetanus, diphtheria, pertussis, measles, mumps, rubella, all of the other vaccines that we give and then monitor to see if boosters are needed. That's all in evolution as well. So this is nothing new or unusual about vaccines.
Okay, this one was kind of a hot topic when the vaccine first came out. So they're asking about blood clots that we're seeing in some patients. If you want to talk a little bit about that.
Sure. So the question was, what about the question of blood clots in people who have received the vaccine? Best thing that we can say, again, going back to science, is looking across the millions and millions of doses. When the issue of central venous thrombosis, specifically in females, came out, the big stink was that, oh my gosh, this is causing a clotting-based problem. But when those numbers were compared to what the normal occurrence of that was, it would appear as though the vaccine was protective of that event. So again, like many things, as soon as something happens, everybody's knee-jerk reaction is, oh my gosh, this is being caused by the vaccine. But when we look at it over statistically, these millions of doses that have been conducted, there is no higher rate of that. There is no higher rate of DVT or pulmonary embolus or any of those types of things. I had a patient not too long ago that came back from a vacation with a DVT and a pulmonary embolus. Well, guess what? That's the time when we worry about you having a DVT or a pulmonary embolus, is after a long piece of travel, especially with a prolonged aircraft flight. That's one of the consequences. But it's easy to understand why people would infer, oh my gosh, I got the vaccine back in January, and now I have a blood clot in my leg. If you hadn't gotten the vaccine, you would have probably gotten a blood clot in your leg. Sorry, but that's how these things play out.
And I think it's the scrutiny and the microscope on everything COVID, not just vaccine, everything COVID, has been such that we have highlighted things that in the medical world would have otherwise been non-events. Mm-hmm. And that is not in any way to take away from the fact that there were a handful of women in a certain age group that had events. But if this would have been any other routine new vaccine based off the overwhelming data in totality, that never would have made any headline on any report anywhere, because it would have been so insignificant in the total number, not insignificant for those individuals, but in the total number. It's just that microscope on it blows it up to a level that we even paused giving the Johnson & Johnson for a short period of time, but then ruled, once looked at it from a science standpoint, that the safety and efficacy profile was certainly there.
Yeah. And one of the things we didn't touch on earlier was pregnancy and breastfeeding. I have a number of patients that ask about receiving the vaccine and the safety of that. I have no reservations with that. The experts in OBGYN, the ACOG organization, all recommend giving that to pregnant women and also to breastfeeding mothers because we have seen the consequences of those individuals who get the infection, what impact that has on their pregnancy. So I have no reservations in that. Our local OBGYNs have no reservations in that either. ACOG, international organization, has no reservations either. So pregnancy, perfectly safe and recommended. Breastfeeding as well.
There's a joint statement by ACOG and Maternal Fetal Medicine Society, and certainly if you're concerned in that population, I would strongly suggest you read that. As a pregnant or breastfeeding mother, those are the organizations that have decades of experience, and they overwhelmingly support the COVID vaccine. And certainly, when you seek medical care, you look for the experts in that field and what their recommendations are. And there's not a gray area. It is overwhelming support. And certainly there have been pregnant women in our community that have had very difficult times in having COVID while pregnant. And I'm sure there would be an attestation to the vaccine is the safer route than taking the risk of getting COVID.
Absolutely. All right. Any other things for this week?
Where can they get the vaccine?
Please.
Good question. So as far as getting vaccinated, ourshot.in.gov is still the best place to go just out of the gate, because you can put in the zip code and it will show you all of the eligible sites to get vaccinated. More specifically, in our community, Knox County Health Department is running vaccine clinics. Our Walgreens, Walmart, Williams Brothers are vaccinating. So those are all sites here in Vincennes, but ourshot.in.gov, you can schedule your appointment. It's quick, it's easy, it's a fluid system that works very well, and there's access every day. So there's really, and it's still federally funded, is free to get vaccinated. So there's everyday access at no cost, safe and effective. There's really no reason not to go and get vaccinated.
And no issue with crossing state lines?
No.
Yeah.
No, it is not just restricted. Early on with volumes, it was restricted to Hoosiers. It is not now. We vaccinate anybody that signs up and shows up. But similarly, if you look at different zip codes, ourshot.in is only going to show you Indiana, but I know health departments in the counties of Illinois that we serve and interact with frequently are also providing vaccine.
Any other things for us this week? All right. Well, thank you very much for joining us. We will have an update again in a couple of weeks. Clint will have that posted for you. With the rate of change, we may have an update for you tomorrow. No. But thank you all for joining us. I'll be looking online and answering questions later if you have other things you'd like to ask. Thank you.